A very good morning to all of you. I'm sorry, I'm actually not well. So the topic which has been given to me is hepatitis E virus entering into hepatocytes, an update. So when this topic was given, I actually thought what is there into it, but then I digged into the lots of literature, and in the last 2 years, although the cases of HEV infection in our developing nation is slightly declining, but West has come up with the zoonotic infection. So a lot of work is happening related to this virus because it's a new virus for them, and now the Western people are after it, and that is why so many articles. So I'll be covering on what is the structure, taxonomy, which has been changed recently, what are the new insights into these proteins and the significance, clinical course and effect on diagnosis, its replication, what are the new insights, how it enters hepatocytes, the quasi-enveloped HEV, which is the very latest, and the clinical implication of these in the form of chronic hepatitis, persistent infections, extrahepatic manifestations, and immune evasions. So briefly recapitulating that it is one of the important causative agents we know, enterically transmitted viral hepatitis, most important cause of acute sporadic viral hepatitis in adult. In India, this infection is hyperendemic. There are 8 genotypes, but humans are infected only by genotype 1 to 4. 1 and 2 are exclusively human, 3 and 4 are zoonotic. However, recently, few other genotypes have been shown to cause infection. Pregnant females are an important chunk of people where genotype 1 infection, which is the most prevalent in our country, can lead to acute liver failure and a case fatality rate of up to 30%. Recently, genotype 3 strains are associated with chronic HEV infection in immunocompromised group, and the sporadic cases of genotype 4 are also reported. However, all these, the exact mechanisms that why different genotypes have different disease outcomes is still not known, and that is why the virus-cell interaction, the quest to find out that what is happening at the level of the virus in cell is coming up and still not very clear. Now this is an excellent article by M.S. Khuru, who has been known to discover hepatitis E. So this is one virus which was discovered in India in 1978, although it was labeled as non-A, non-B, and then the name was given by the Russian soldier Balayan in Afghanistan war. So many latest things are happening, like the mystery of HEV, how it is replicating in vivo and vitro, autochthonous, which I said, zoonotic transmission, how it is causing chronic infections, and how the pregnant females now with this new role of ORF4 region in the virus has shown to be causing that it is genotype specific pregnancy outcome. Now, when we were students, hepatitis E virus belonged to the Calliciviridae, but recently in the year 2004 and subsequently in the year 2009, a new family, because it was shown that it should be characterized into a new family, Orthohepiviridae family, it has been classified. There are many, so the recent thing is that apart from humans, you have so many other animals which have got this hepatitis E virus, though the human-to-human infection occurs in genotype 1 and 2, few cases of genotype 3 and 4. Recently, rat hepatitis viruses, they have shown, belonging to the Roca-Hepiviridae family, has shown the transmission into humans and from the camels also. Now, these human genotype, their distribution is as per the geographical locale. In our country, we have genotype 1 infections in humans, although genotype 4 in pigs is there, but we have not still reported any case of 4 causing infection from India. And whereas in the Western or the developed country, the infection is zoonotic. It can also cause chronic infections, and it has shown not a very severe course, but it is prolonged existence of the virus has been shown, and it is treatable by ribavirin or pegylated interferon. So clinically now, apart from enterically transmitted, it is also transmitted through, as you can say, so many vegetable, fruit, seafood, camel, milk. So and now we classify hepatitis E virus into causing infections in immunocompetent and immunosuppressed separately. Immunocompetent, usually asymptomatic, or it can be overt hepatitis E, but recently extrahepatic manifestations and severe outcome in underlying chronic liver disease has been reported. In immunosuppressed, it can also lead to ALF, ACLF, and also the chronic form of the hepatitis. Now, till now, this is the only first EASL guidelines, which are the clinical recommendation which has come up recently, where they tell you the whom to test. Normally, it's a very simple virus. It enters, IgM antibodies are formed, and IgM antibodies, they coincide with the peak ALT derangement. Genotype 1 or 2 infections, usually the virus remains for 1 to 2 week duration in the blood. However, in the feces, it can be there for 3 to 4 weeks, but this is, the concept is changing. EASL is the only clinical recommendation which have shown that whom it should be tested. And now they say that an immunocompetent, any person who has a biochemical evidence of hepatitis, DILI, if it is suspected, check for, by HEV IgM, decompensated chronic liver disease, HEV investigation, and in the form of extrahepatic manifestation, if you have a neurological myotrophy, Guillain-Barré syndrome, unknown encephalitis, and unexplained acute neurological or with the raised ALT, then go and look for HEV IgM. And immunocompromised, if it is persistently abnormal ALT, HEV IgM needs to be done. Now, coming to the topic, that how it enters the host and its replication. So before going into this, I would like to tell the characteristic features of important viral structure. It is a 7.2 kb. It is a single standard positive sense RNA virus. Important are the 3 regions, ORF1, 2, and 3. These are the open reading frame which forms the proteins. And ORF4 is recently found to be associated with the ORF1 in genotype 1, and it is incorporated inside it. And this has an effect on the active viral replication, especially in the pregnant females. So the virus, it forms 2 types of genomic RNA, one which is 7.2 kb and a subgenomic RNA which is 2.2 kb. The capsid protein recently, so the unique features which has come up are the quasi-enveloped form which is of the HEV which is circulating in the blood. The capsid proteins, 3 domains which are described. So, yeah. So this forms the genomic RNA which is 7.2, and you have the subgenomic RNA which is 2.2. The interesting is, I'll be talking about the quasi-envelope, but the 3 domains inside the ORF2 which are S, M, and protruding, and then ORF3 which is the polyfunctional. So what are the new things which have come is the quasi-envelope form, the 3 domains and their role, and ORF4 region which is present only in genotype 1, which can lead to severe and affect the replication. Now, ORF1, not much changes has been seen and reported, except that this RDRP region, which is RNA-dependent RNA polymerase, this affects the viral replication and is essential. And if any change or anything influencing it comes, then it gives you, increases the viral virulence and pathogenesis. And this is the basis of ORF4 region in genotype 1, that it increases the RDRP activity. Another thing is the hypervariable region, which decides its host adaptation, and mutations have come up which is shown, and that is why the rat-associated hepatitis E virus and other hepatitis E viruses in various zoonotic animals have come up. Now this is important, that what is the changes or what is the new about ORF2 capsid protein. As I told you, that it has got 3 domains, and this ORF2 forms the capsid, that is the cover of the virus. There are 3. So the virus is released in 3 forms by this capsid protein: ORF, infective, infectious, glycosylated, and cleaved. So there are 3 forms which are circulating in the blood of the capsid, the capsule or the cover of the virus. Now it is the glycosylated and the cleaved form which are most abundant in the antigens. The studies have shown it that in the patient sera it is the highest, and this glycosylation causes can be bit different. So this amount of glycosylated capsid protein differs from genotype to genotype. Now this glycosylation also influences so you have a glycosylated capsid protein which allows this virus for immune evasion. Till now, we were not aware that hepatitis E virus, we used to think that there is an infection, there occurs IgM and IgG, and they are the neutralizing antibody which takes care, and the virus infection on its own gets controlled. But these new insights have shown that they cannot be neutralized and they can inhibit antibody-mediated neutralization, and the virus actually evades the immune detection. And so the entire insight of the vaccine, the issues of hepatitis E virus vaccine, whether to use, comes to the ground one, that if it is capable of immune evasion, then what are we targeting, how to prevent this infection. ORF3 is another interesting protein. Earlier it was thought that it is only used for release of the virus, but now there are two forms. So the virus exists, I will show you how it comes, in the blood in a quasi-enveloped. So you don't have true, so it is a non-enveloped virus, but once it is egressed out of the cell, it forms a lipid coat, and this is the quasi-enveloped, and this quasi-enveloped is also associated with viral protein. So it is not only the lipid layer, which we thought, but it also has got some viral protein. The exact nature that these ORF3, which is situated in these quasi-enveloped, is there are a lot of articles and speculation, but exact that why it is present, and then this quasi-enveloped form has been associated again with immune evasion and delayed neutralization by the specific antibodies. So you acquire an infection, the antibodies are formed, but virus through two mechanisms. One, the glycosylated ORF2 protein, and the other is this quasi-enveloped form tries to not get neutralized by the neutralizing antibodies are formed. And this is something which has come up very recently. Now, genotype 1, since the talk was not on the pregnancy, so I have just quickly tell you that it is the ORF4, the fourth protein, which is specific to genotype 1, enhances the replication of the virus by influencing, as I told you, RDRP region of the ORF3. And that is why now, apart from the hormonal influences, the genotype 1 ORF4 has been shown to be most important factor which causes severe kind of hepatitis and ALF in pregnancy. So earlier, we used to think that it is the hormonal factors or other factors, but now clearly it has been shown that it is the ORF1-4 region in the genotype 1 which causes this high replicative state of genotype 1 in pregnant female, apart from the other factors. Now, another new thing is that how it enters. So we know it is fecal oral transmission. So earlier it was thought that from the intestine, the virus just goes to portal blood, and it is essentially hepatotropic virus, means only hepatic tropism is there. But now many other sites, and especially the intestinal cells, the enterocytes have been shown, which is the primary site of infection. So the virus not only replicates in the hepatocyte, the initial entry is there inside the enterocytes, the intestinal cell, where again two forms of the virus, the quasi-enveloped and the non-enveloped, the naked virus is released. And it is released in the ratio of 80% is the quasi-enveloped goes to the blood, and it's just the 20% of the naked, that is non-enveloped virus. And this virus, how it enters the portal blood and then it enters the hepatocytes again, then so one site of replication is intestine, then it goes into the second site, which is the hepatocyte, and there again the virus replicates, gets released into the biliary caniculi as the quasi-envelope, but the bile destroys the lipid envelope, and inside the blood it is the quasi-enveloped or the lipid enveloped virus which is circulating. Now, what is why the enterocyte replication is important, because so many times the reinfection or there is a prolonged occurrence of HEV infection which is unexplained, and lot of virus inside the blood can be that apart from liver there are other sites of replication. Intestinal cells has shown to be for all the genotypes 1, 2, 3 and 4, and so this tells you about sometimes the prolonged and reinfection. Now, coming to the cycle, so I told you there are two types of hepatitis E virus, one which is the naked and the other is the quasi. So, in the blood, both of them, so the ratio of existence is that this type of is 80% and this is just 20%. This enters into the hepatocytes through receptors, query, clathrin mediated and heparin sulfate, while this enters through the endocytosis. Genomic, subgenomic RNA, ORF2-3 are formed, the virus, and then the virus is released into the blood as quasi-enveloped, carrying the ORF3 protein also. While what goes into the bile, by bile, the quasi-enveloped as well as the ORF3 is destroyed, and only the naked or the unenveloped hepatitis E virus is there. So this is something that ORF3 is associated with the majority chunk of the virus which is in circulation, while one which is excreted out in the feces is the non-enveloped. The non-enveloped nature of the virus also allows prevents the degradation and allows its environmental existence, but inside the body, you have a quasi-envelope along with the viral proteins also. This is again showing the same thing. So now we know that in the blood you have the quasi-enveloped virus, and the release is not by the cytopathic. So it does not cause, as I told you, the release of the virus is endosomal ESCRT sorting complex it's required. So it does not cause the damage to the cell. So it is not causing cytopathic effect, it is released out. The lysis of the hepatocyte occurs because of the immune reaction which the virus mediates. The virus, because of its quasi-envelope, is capable of causing immune invasion, and because there are other sites involved like intestines, literature is coming, the kidney, are also the sites, and neuronal sites are also there where the virus can replicate, and ORF3 somehow is associated when it is released as a quasi-envelope form. So is it a quasi-envelope, or now we know that there are extracellular vesicles also where the viruses are involved. So clearly it is shown that the virus is quasi-envelope. It is nothing to do with the extracellular EVs where the virus is there. How they have come up with this evidence that these are smaller than the EVs, which can be through the autophagosomes or through the MVB shedding, and usually these ones are multiple. They can be heterogeneous. The size varies. In the EVs, they can be multiple viral structures, and there is no expression of any viral protein, while this quasi-enveloped is always associated with a viral protein, and it is formed by the non-enveloped. So it is clear that the virus which is quasi-enveloped is not a extracellular vesicle. The extracellular vesicle release is separate, and this quasi-enveloped is separate. So I told you that there is extra hepatic sites for replication, and the release of the virus is not cytopathic, but it is quasi-enveloped. What is the clinical significance? So people are now, a lot of literature is coming that this is responsible for persistent and prolonged infections. Sometimes the infection becomes resistant, and repeated reinfection. So intestines becomes the site or seeding site for again and again infecting your hepatocytes. Then there are, because I told you that ORF3 is also there, there is immune evasion, so it is associated with lots of inflammatory responses inside the body. Chronic HEV infection is based on this concept only because it replicates slowly, so it can cause chronic infections. Extrahepatic, I told you. And then it is also, whatever antivirals you have, there is resistance, and there is decreased responsiveness to the hepatitis E virus vaccines which are there. Now this is, Dr. Seema ma'am would agree, was a case, and now I am rethinking about this 4-year-old child from ILBS who was post-LDLT, and we had, and it was a case of EBV-associated lymphoma, Burkitt's lymphoma. Along with it, there was hepatitis E virus, and we could demonstrate the presence of this hepatitis E virus for up to 34 months post, both in the blood as well as in the stool. And it was of the log of 10 to the power 5 to 4. It was genotype 1. The virus did not show any mutations or specific abnormalities, but there was a persistent release. However, we have not yet published, but there was, ribavirin was also given, and it was resistant to this ribavirin. So this explains, now looking at this case scenario, such case scenario could occur where there is HEV, which is not causing chronicity, but there is a prolonged reseeding of the infection and prolonged persistence of this viral infection. Chronic HEV, we call HEV is chronic when the virus is shed in the blood and in the feces for beyond 3 months. So continuously for 3 months, the virus is not cleared. And usually it occurs in solid organ transplants. Now, there are a lot of studies which have come up. This was a systematic review which has shown that the occurrence of HEV in the solid organ transplants is about 20%. That's quite high. And although the de novo and acute infections are a major chunk and high burden, but still the liver transplant recipients, apart from kidney and heart and lung, have got highest, so 27.2 pooled prevalence as compared to the lung. So the lung transplant is slightly less. In India, genotype 1 has not shown chronicity. However, a recent report from PGI Chandigarh has shown that there was a prolonged, and the one case we have not published from ILBS where there is a prolonged persistence of HEV infection. We also looked into transplant patients as a retrospective study, and we did not find this infection to be causing chronic, genotype 1 causing a chronic infection. Now, what is the importance of the other sites apart from the liver? The importance is the extrahepatic manifestations which are associated with HEV. The virus has shown to be replicating inside the hepatocyte, inside the intestinal cells, kidney cells, neuronal cells. And a lot many times, as I told you, the EASL criteria is also that if you have neuronal amyotrophy or Guillain-Barré syndrome, unexplained cause, you must look for an HEV infection. And lot of, this was another case report. Now we are getting to know that because of the extrahepatic sites, we reported long time back in 2018. It was a 30-year-old male who came to ILBS with AVH, demonstrated significant Guillain-Barré syndrome, referred to Fortis, and again from Fortis we kept on collecting the sample, and we showed the persistence HEV RNA for more than 50 days. Although the patient recovered, they started ribavirin and responded well. All the GBS symptoms were taken care of. What are the antivirals which are available? You don't have specific antivirals. However, the antiviral agents which are used for another RNA viruses like favipiravir, which is an RDRP inhibitor, has been shown but not successfully. Ribavirin has been used. The sofosbuvir are being used, but ribavirin has been persistently used, and favipiravir, which is being used in treating the HEV infection, although specific antivirals are not available. So what are the vaccines? So HEV 239, which is a capsid, ORF2 capsid-based Hicolin vaccine, is the only one which is approved, licensed. It is being used in China, and very recently in Pakistan, it has been used. Again, the efficacy of this vaccine, although it has shown very good and with 93% long-lasting immune response, but with the new insights of ORF2 existing as a glycosylated form, whether it is really effective or not needs to be established. I don't think so in India any of the clinical trials are there. There are other vaccines which are there, but they all are based on ORF2 region. And the newer insights of this ORF2 region, which shows that this is in the glycosylated form also available, capable of causing immune evasion, is forcing the scientists to look for the other candidates of this vaccine. This is a very recent article which has come up, and I felt like sharing because this raises the concern regarding the efficacy of the Hecoline vaccine in pregnancy. They have shown when this vaccine was given to pregnant females in the first 90 days, it was associated with exaggerated deaths, which is what we don't expect that. So, but they have shown that somehow when you give ORF2 based vaccine, it stimulates a lot of inflammatory pathways, and whether the ORF2 should be used as a vaccine candidate because it is capable of causing immune evasion has come up. This is very recently in the November 2024 issue. This trial has shown that the pregnant females who received this vaccine during the first trimester, they were associated with more severe outcome as compared to those who did not receive. This is something alarming. So the new concept is that HEV is capable of immune evasion, and it's the key aspect of its pathogenesis. It allows the virus to persist in the host and can cause the chronic infection. So HEV has got lots of strategies by which it can evade the immune responses as well as the T-cell based immune responses. So innate, humoral, as well as the cell-mediated immune responses. Virus exploits the weakness in the host adaptive immune system, and that is why the prolonged replication and prolonged infection is there. The new insight is that it can also establish itself as a latent infection in certain tissues apart from liver, and can lead to sometimes get reactivated and can cause persistent overt symptoms. And although not many good studies are there which can prove these effects, these are only speculations. So I summarize that in the last decade, significant information has come about hepatitis E virus pathogenesis and virulence. Although in India, and especially in our institute, we are seeing a declining trend in the infection. We are not seeing a lot of HEV infected adults coming up, but there are still focal outbreaks which are reported. But there is lots of rise of cases in the developed country, and especially by the zoonotic types like genotype 3 and 4, which is a matter of concern, and especially in immunocompromised patients. The quasi-enveloped HEV and the existence and into the other sites of HEV replication like intestines, these are the important findings recently, which can cause persistent infection and can cause lots of damage. Immune evasion by HEV raises concerns about available vaccine candidates. Thank you.